Hello everyone, my name is Lauren McCormack and I'll be discussing tubing the gallbladder, management, and the interval cholecystectomy. I have nothing to disclose. So who gets a cholecystostomy tube in the first place? It's essentially those patients that are too frail and too sick to undergo general anesthesia and a cholecystectomy at the time of presentation. So across the board, reasons in the literature is intolerance to general anesthesia, systemic sepsis, symptoms greater than 7 days. So those patients that have been suffering with gallbladder symptoms and their inflammation, where there's evidence of on radiology that shows that it's too great to safely undergo cholecystectomy at this time. And those with anticoagulation that either cannot be stopped or, those patients on a NOAC where it takes several days to reverse the effects. Throughout the presentation, I'll be citing the Prevent Bile Duct Injury Consensus Conference guidelines, and they state that a Tokyo grade 3 or greater acute cholecystitis and unable to undergo cholecystectomy should undergo cholecystostomy too. Those with less acute cholecystitis may just try antibiotics alone. But essentially, they summed it down to those that are too frail, too sick, too late of a presentation, and if you do not have the available resources to safely get that person through a cholecystectomy, such as no ICU capabilities in the rural community, those people should get a tube. So what are the outcomes? So it's a very effective tool against resolving cholecystitis, about 90%. However, it is associated with some increased length of hospitalization, increased costs, and increased mortality, which some of those things can be attributed to the patient's comorbidities that's preventing them from getting the cholecystectomy in the first place, but also things to be aware of. These also have higher 30-day readmissions. Some are due to the comorbid conditions, but others are related to tube complications such as dislodgements, leaks, and even bleeding and skin site complications. Now, is a cholecystectomy always necessary after a cholecystostomy tube? And the answer is easily no. So non-operative management has been well described and used in several modalities, which I'll discuss a little bit later. But of all patients who get cholecystostomies, only about 30 to 55% in the literature end up going on to get a cholecystectomy. Now, some of these patients succumb to their comorbidities, but a lot of patients do end up just undergoing non-operative management. And non-operative managements include like a graded cholecystostomy tube removal, which can be adjuncted with a percutaneous stone removal under fluoroscopy. Now, some patients that are just too frail and sick to undergo anything can just live with their chronic cholecystostomy tube, and there are some endoscopic gallbladder drainage procedures. Now, the BDI Consensus is essentially low-risk candidates who have these tubes should undergo cholecystectomy. For those high-risk candidates, they do recommend that some non-operative or medical management approaches could be used as they are too high risk to undergo general anesthesia and a cholecystectomy. Now, what defines high risk? So through the literature, there's a myriad of conditions that are listed on the left. However, the most consistent ones here on the right are the most likely to undergo non-operative management. And those are patients older than 65 in age. They have higher comorbidity scores, and cirrhosis and diastolic CHF seem to be the two leading diagnoses that push people towards non-operative management. So what are some of the outcomes? So in about 11% of patients, they do require some kind of emergent operative intervention, even with having a cholecystostomy tube in place. Now that can be attributed to recurrent or non-resolution of their acute cholecystitis, even with the tube. They can also move on to have choledocholithiasis requiring some intervention. These patients can also have bioleaks from dislodgement or even misplacement of these tubes. Now, the patients that do undergo true non-operative management, about a quarter of them end up needing some kind of reintervention. Now, whether it's a repeat placement of the tube or even just a cholecystectomy in the future. Now, if you're going to go the graded non-operative tube removal timeline, so you're going to see these patients for an IR tube or in cholangiogram about 2 to 4 weeks after placement or discharge from the hospital. And so what they're going to do is they're going to check for one position of the tube, but they're also going to check for cystic duct patency, which will be important for determining if this patient will be a non-operative candidate. You can also see if the cystic duct is patent CBD pathology, such as choledocholithiasis. can also see if this patient has retained cholelithiasis, and it might put them at risk for repeat symptoms in the future. If your IR tube check all goes well and you're still down the non-operative path, around week 4 to 5, you're going to see them in the office and try to clamp that tube. You want to clamp it for at least 7 days and then see them back in the office no less than a week. You're going to evaluate them, check for any kind of systemic symptoms, nausea, vomiting after eating, any kind of fevers, and examine them for any jaundice or right upper quadrant pain or tenderness or a Murphy's sign that was not there before. Patient is clinically and symptomatically negative for any effects of the clamp trial, you can go ahead and remove that tube and observe them. Now, indicators of non-operative failure, so any kind of CBD pathology, particularly choledocholithiasis, you need to address that bile duct before removing that tube. Cholelithiasis, so you can remove the tube if they do have cholelithiasis, but just keep in mind that they do have a higher risk of recurring their symptoms. If they're intolerant of that clamp trial, you cannot remove that tube. And then if this is their second or third placement of their cholecystostomy tube and you're trying non-operative management again, expect a high suspicion that this patient will fail again, and you may need to go down some other routes to resolve this patient's issue, or they may become a chronic cholecystostomy tube patient. So what are some of your non-operative treatment failure options? Now, go ahead and do the cholecystectomy, understanding it's going to be a hard case, and keep some of your bailout techniques in your back pocket. Other options that are more that are newer to the fold are your endoscopic drainage. So there is the direct duodenal drainage through the self-expanding metal stent, which you can see here. So essentially yourself, if you're that skilled, or your interventional gastroenterologist will place a self-expanding metal stent directly through the second portion of the duodenal wall into the fundus of the gallbladder, allowing direct biliary drainage. Now, this is a good option if your cystic duct is occluded. Another option is essentially an ERCP approach that we're more familiar with, where the GI endoscopist accesses the ampulla, goes up the bile ducts, and actually stents through the cystic duct into the gallbladder fundus, therefore draining the gallbladder lumen, the cystic duct, the bile duct, all the way through the ampulla. So this takes usually a patent cystic duct. It's very difficult if it is occluded, and a very skilled endoscopist to perform. Other options can continue to be a chronic cholecystostomy tube, and there's always transfer to a tertiary hepatobiliary center for a higher level of evaluation. So some of your operative management considerations is time, techniques, and complications. So preoperative considerations, so you want to really have a multidisciplinary approach to this. You get all of the subspecialists involved in your patient's care: cardiology, pulmonology, hepatology. And you can't leave out your anesthesia colleagues. Last thing you want them to do is be surprised on the day of surgery with such a frail patient. And also have good post-operative, immediate, and long-term plans as far as with these specialists and the care of this patient. You also want to get one of those preoperative tube studies or cholangiograms, if possible, via the cholecystostomy tube. It'll help give you a great roadmap for predicting your surgery. So is your cystic duct patent? Is there any duct pathology? Is there a stone impacted at the neck of the gallbladder? It might be creating a Marizzi type syndrome. These are all things that you can learn from this tube study and kind of help plan your attack. So timing. So when should you actually proceed with this cholecystectomy? So traditionally, we've all learned like wait 6 weeks, trying to get the inflammation to resolve. There was a good study at Stony Brook that looked at early versus delayed, with the 8-week mark being the cutoff. So they saw that patients that underwent cholecystectomy less than 8 weeks had longer length of stays and overall complications. Good thing that the CBD injury, however, was the same for both groups, no difference in readmission. However, the increased overall complications is something to be cognizant of, as well as the longer length of stay. I think the overall thinking is, wait as long as possible, get as much of this inflammation down before proceeding with this procedure, and it also gives you more time to get these patients more medically optimized. There's no rush to take these patients to surgery. So operative outcomes. So these patients, there is a higher risk of bile duct injury at 1.6%, which is something to be cognizant of, as well as planning your surgical approach, as well as something to think of during the operation is really defining your anatomy. Post-op complications are as high as almost 35%, which goes along with some of their comorbidities as well as bile leaks, wound infections. As such, these patients have a slightly higher mortality at 2.3, and there is a higher incidence of conversion to an open procedure and actually just primary approach of an open procedure with these patients. And why does this occur? As we all suspect, these are challenging cases. These patients are sicker, frailer, they have difficult anatomy. The gallbladder is usually contracted down due to weeks of decompression and scarring, and as such, adhesions form to the duodenum. The gallbladder can even adhere itself to the bile duct as well as the liver and the colon. So what are some techniques to help successfully get you through this operation? So I always keep and prep in the tube for use during the procedure, mainly for a tube cholangiogram. Now, the bile duct consensus is that you should liberally use intraoperative cholangiogram whenever you can, and particularly if your cystic duct is patent, you knew that going into this procedure, you have an easy cholangiogram whenever you need it. Now, if your cystic duct isn't patent, you can still use this as a roadmap. You can see where the gallbladder is, and more importantly, isn't during your dissection, and you can go between, fluoroscopy and intraoperative looking to get an idea where things are. Now, if you're facile with intraoperative ultrasound, it is recommended if you have the skill set and the technology. Now, some of the operative techniques, in addition to using the tube as a roadmap, you can also use it mechanically during the operation. So sometimes the gallbladder is hard to find where the fundus begins or where anything else ends, and you can use the gallbladder to know, or the cholecystostomy tube to know exactly where that fundus of the gallbladder is. You can also use it for retraction, particularly if the colon or the duodenum are completely covering a contracted gallbladder and there's no safe retraction space. You can use that as a hold until you can get enough of those adhesions down that you can get a hold on the gallbladder. Now you can use your standard or dome down techniques, whatever you're most comfortable with. I think most of us try with the standard first. However, with the nature of these cases, the scarring, it is sometimes very difficult to get those good anterior and posterior views of the triangle below. So at that point, you can use your tube and use it as a dome down technique. Use the tube as a guide, start your fundus, and start with the easy stuff, pulling that gallbladder down, and hopefully it'll show you some easier anatomy. And then there's always your bailout technique of a subtotal cholecystectomy. So the consensus conference is that the subtotal cholecystectomy is an approved measure when you cannot get a safe dissection that can show you all of the anatomy that you need. So the two most common options that we see is the reconstituting and the fenestrating subtotal cholecystectomy. Now with the reconstituting, you essentially do a dome down technique as far down the infundibulum as you deem safe and as you can. And then you essentially either staple or suture across the remaining gallbladder, creating like a new neo gallbladder. Now as such, it's associated with a slightly increased rate of stones. There's always the fenestrating as well. So the fenestrating is you take down the anterior wall of the gallbladder and ablate the mucosa. That leaves you with an open cystic duct orifice. Now you can or cannot close this. While many people don't, there is no consensus. Now with either of these procedures, you would likely want to leave a drain. Now with the fenestrating, definitely with the drain, you want to ensure that there is slightly a higher bile leak post-operatively with that procedure. Usually it's self-limited and resolves without any further intervention, but having your preoperative tube study and knowing if your cystic duct was patent could help you guide between which of these two approaches you want to take. With a patent cystic duct, I may lean towards the reconstituting opposed to the fenestrating approach. Thank you very much, and I look forward to the panel discussion.